Good afternoon, ladies and gentlemen, dear colleagues. I would like to welcome you to this exciting session. We will focus today on intravenous antiplatelet agents for acute and complex PCI. Today, in this session, we will discuss not only how to use cangrelor and intravenous antiplatelet agents, but these presentations will be informed by clinical cases, by new data from registries across European countries and US. We will also focus on the transition from the intravenous agents cangrelor to oral P2Y12 inhibitors, as well as the state-of-the-art use of antiplatelet agents with the focus on intravenous agents in acute and complex PCI. My name is Jolanta Sila-Matua. I'm professor of cardiology at the Medical University of Vienna, and I'm very delighted to welcome and to introduce our international panel of distinguished speakers. So I will start from right to left. Dr. Friedrich, also from Austria, our three USA-based experts, Professor Meran, Raima, and Angiolillo, and Dr. Cao from Italy. So I'm very confident that you will leave this session with new insights and inspiration for your clinical practice. And with that, I would like to ask Dr. Angiolillo to introduce our first speaker.
Thank you so much. So we will start with the first presentation, which will be a STEMI case in the pre-shock conditions. And this will be by Professor Friedrich, and who will also be speaking about the ARECA registry.
Thank you, dear chairpersons, dear speakers, ladies and gentlemen. Thank you for the invitation to be here. These are my conflicts. I just would begin with a case which is kind of representative for the registry. You will find a lot of patients in this registry showing a similar clinical aspect than this compared with this gentleman. A 70-year-old patient with a high risk profile. You see it, metabolic syndrome. He had already a story of PCI of the RCI some years ago, PCI and stenting also of the marginal branch in 2005. There is a known intercurrent AF, known chronic renal failure, and very important for the next slides, an anemia, which is also chronic renal and ongoing iron deficiency. He has an obstructive sleep apnea syndrome, and there was a surgical occlusion done of an atrial septal defect in 2000. So the index event, the patient was presenting with severe typical chest pain at 2 in the morning, and the first medical contact was done half an hour later. You see here the pre-medication of the gentleman with edoxaban, insulin, and other good therapy. Then the clinical status at the arrival of the emergency doctor was pre-shock situation, severe dyspnea, hypotension, tachycardia, and nausea. And the first EKG, don't be afraid, looked like this. So not very nice, because you see a large ST depression in 1. You see it also in V2, V3, V4, V5. You see an ST elevation in V1, and you see it also in AVR. So there is a suspicion of left main. There is a suspicion of a true posterior infarction, maybe. This is the second EKG written at our center 30 minutes later. So the emergency doctor was very quick to be at our center. You see here the first medication given by the emergency doctor, aspirin, morphine, diuretics, antiemetics, and the patient was there. Still not in a good shape, of course. And then this is very interesting. You see the first blood sample drawn. You see here there is a normal troponin. There is a CK, which is practically normal also. You see the hemoglobin 7 points. So severe anemia, but the enzymes are rather normal. See here the cath. The right coronary artery showing 2 stenosis, one in the middle, one distally. A rather small vessel. But probably this intrigues you more. This was the finding of the left main, severe left main stenosis, 95%. There is a hidden proximal LAD stenosis also. You see a nice stent in the marginal branch of the circ. The main circ is very small and has also a 99% stenosis. So it's a kind of trifurcation, but nevertheless severe stenosis in the left main. After the intubation of the coronary ostium, sudden cardiac arrest arrived with need for oxygen mask, ventilation, atropine, adrenaline. And the patient was shortly unconscious. Low blood pressure, manual CPR for 2 minutes. So we went just through a pre-shock situation and into a shock situation. Nevertheless, there was a ROSC with a patient still with nausea, vomiting. Antiemetics were given, and another morphium bolus was given. The patient was then remaining hemodynamically stable, but somnolent and unable, of course, to swallow any medication. The hemoglobin was dropping, and we went for 2 immediate transfusions. So the questions, of course, are now, which antiplatelet, anticoagulative strategy precast? Which strategy to apply, knowing the coronary anatomy? Should we go for surgery? Should we go for PCI? And which antiplatelet strategy after the interventional procedure? So you know from the comorbidities, this is not a good surgery patient. So we went for a PCI of the left main and the proximal LAD. And this was done with a guideliner because there was heavy calcification also. So we fixed first the proximal LAD with a 3.5 stent, and then went for the left main with a 4.5 stent and with a pot, and we reached a very good result at first. So we left the RCA and the circumflex untouched. So these are the medications afterwards. Heparin bolus peri-interventionally, then we gave a cangrelor bolus and an infusion. You see here for 2 hours, 96 milliliter per hour. After this, the patient was switched to clopidogrel per a gastric tube. Remind, edoxaban was on hold, of course. He had AF, and all the other medication is here. We could reduce noradrenaline infusion after 2 days completely. The patient recovered, and you see here the post-PCI EKG, which also shows a nicer result than before. So I switch now to the registry. The registry is called EuroPCR. You see here, Austrian Registry for Cangrelor Application. It's a countrywide analysis with indications, clinical use, safety and efficacy, investigation. We included 1,700 patients in this registry until now, so we are still recruiting. We are over 2,500 now for the moment. You see here the 7 primary PCI centers in Austria, all over the country. 3 in Vienna, 1 in Graz, 1 in Klagenfurt, 1 in Feldkirch, and the core lab was back home in Innsbruck. So you see here the primary endpoints. The analysis in hospital, we just analyzed the in-hospital major bleeding versus MACE rates, cardiovascular death, non-fatal MI, and non-fatal stroke. You see the demographics of the patients, mostly male patients. They received 1.8 stents in average, and most of the patients were done femorally. This has several reasons which we can discuss maybe later on. The clinical presentations are here, mostly STEMI patients, 46%, 25% non-STEMI, 28% stable, and 27%, so a large amount of patients were intubated. Multivessel disease in 38%, left main 9%, 60% LAD, and in 12% of the patients we did thrombus aspiration. The medication, cangrelor application, you see here the durations, you see the bolus rates, you see the infusion rates, and the pre-PCI, peri-PCI, and post-PCR medications are listed below. You see here there is a large variation of the second oral antiplatelet agent, clopidogrel, ticagrelor, and prasugrel were used. And which I want to stress out a little bit is the timing of the oral antiplatelet therapy loading dose. You see 39% received it before the infusion stop, 35% at the infusion stop, and 26% post-infusion stop. The endpoints are here. 5.9% had major bleeding, BARC over 3A. The hazard ratios were 3.3 for intubated patients, Also, an elevated hazard ratio was there for multivessel disease, thrombus aspiration, and for anemic patients. And the MACE rate was 13.1%. We had 8% cardiovascular deaths in a very, very sick patient cohort, and about 5% non-fatal stroke and non-fatal MI. And there was no significance, but there was a large trend for the mean starting time point of oral antiplatelet therapy. You see it here. In patients with MACE, you see a -14 ± 147 minutes before cangrelor discontinuations. And in the patients without a MACE, this time was longer. It was not significant until now, but nevertheless, you see a trend there. So we conclude that in this nationwide retrospective registry, where we addressed the use of intravenous cangrelor in predominantly ACS patients and in a very sick cohort receiving PCI, we saw a safety and an effective index hospitalization results. A longer cangrelor infusion before starting the oral antiplatelet therapy showed beneficial effects. Considering this very, very high-risk patient cohort, this data cannot be directly compared in our eyes to the existing champion trials, where STEMI patients were largely underrepresented and only clopidogrel was used as an oral antiplatelet agent. Thank you so much.
Thank you very much, Dr. Friedrich, for sharing your expert opinion and the Austrian data on cangrelor. And this presentation is open for discussion. Are there any questions or comments from the audience? No questions. So, and if you would like to send us questions, you can do it also, of course, via the app. So we will receive them. So, Guy, could you please describe the included population in the ARECA registry a little bit more? It seems to me that the patients were really very sick, many of them. Like 1 in 3 patients were intubated or resuscitated, so they represent very sick patients' populations. And you presented that anemia, actually, and intubation were independent predictors of major bleeding events. Could you elaborate on that?
Yes, thank you for the good question. So we have to remind the patients were very sick, and of these 30%, there were many, many patients resuscitated before. So they went not only intubated, but after resuscitation. So this is a very sick cohort. And the other point is there were many patients with anemia also in this patient cohort. This may be a little bit confusing because they were not all on renal failure or chronic failure. But nevertheless, we wanted to extrapolate this because we see that even if we go for a more aggressive antiplatelet therapy, also these anemic patients may have good results afterwards.
I have a question. So you included very high-risk patients presenting mostly with ACS. Presumably, some of these patients may have been pre-treated with an oral P2Y12 inhibitor. So my question for you is, do you have any concerns with using cangrelor in these patients? Because this is not the way the trial was done, the first. And the second is, what do you do when you stop the cangrelor infusion in those patients who were pre-treated? Do you give another loading dose or not?
Okay. So the first thing is that this doesn't bother us at all. So if they are pre-treated, when we see these patients, we go for cangrelor in these cases also, because we don't think this made an impact on any bleeding or any problems, because we saw the ischemic problem higher than the bleeding problem in these patients. And you never know exactly when did they start with the antiplatelet therapy. Is this reliable, what we are experiencing in these cases? And the other way, the dose is we continue on the dose. We are not decreasing the dose with the first infusion rate.
So maybe I will ask you another question. If we are talking about pre-treatment in Austria, in STEMI cases, in non-STEMI cases, if the patients are pre-treated which P2Y12 inhibitor is administered to those patients, because this for cangrelor plays, of course, a role.
Yes, that plays a role. But we have some SOPs in Innsbruck, at least in the STEMI network. They are pre-treated by the emergency doctor when they come normally, not in this case, but they are pre-treated with a loading dose of prasugrel for the STEMI. And the non-STEMIs, they are not pre-treated except for heparin and for aspirin.
So if the patient was pre-treated with prasugrel and you are starting with cangrelor, do you reload the patients with prasugrel at the end of the infusion?
Yes, they get a reloading after the procedure, after the infusion stop, yes.
I have another question. So you showed how the longer infusion, these patients tend to do better. With the understanding it's observational.
Yeah, that's what we are.
So what do you attribute that to? That those with maybe shorter duration, they're getting an oral drug which is essentially not working, right?
Yeah.
Because these are sick patients receiving opiates and not absorbing. So what do you think?
Yeah, we are discussing a lot about this question. I think maybe there is some stent thrombosis issue in this, because we heard about stent thrombosis, and probably this helps a lot more because we didn't see any impact on the bleeding rates. So that's why I'm asking myself, why not longer? And I think the longer duration probably helps against ischemic problems afterwards.
We have a question from the audience.
Yes, thank you. I'm not sure, but I think I saw that you included also patients with chronic coronary disease. What was the main indication for cangrelor if it wasn't to promote ad hoc angioplasty, or are there any other reasons? Or?
Yes, thank you for the question. Of course, we included stable patient in this registry also because it was operator decision when he saw a very complex anatomy, where three-vessel disease, left main disease, trifurcation, bifurcation, whatever. Then they, of course, included also stable patients, and cangrelor was given.
To perform ad hoc PCI,
ad hoc,
and those patients were not under other dual antiplastic therapy.
They were not all treated ad hoc because they were not emergency patients. So some of them were discussed with surgeons, whatever the revascularization strategy is. But when they went for PCI, then cangrelor was given.
In addition to another...
In addition, because we think that the ischemic problem is lower.
Thank you.
So thank you very much, Dr. Puzli. And now it's my pleasure to welcome Dr. Reimer, who will be presenting the American perspective on the use of cangrelor and also the real-world clinical data on the Cameo registry. Jennifer, the floor is yours.
Thank you. All right, I'm going to start off with a case of cardiogenic shock that I took care of a couple months ago, because I think it's a nice illustration of where cangrelor can be useful. So this was a 65-year-old woman. I don't include her medical history because she essentially did not have a known medical history, had not been seen by physicians in the past 5 to 7 years. Here is her presenting EKG to our emergency room. You can see significant ST elevations, very ischemic presenting EKG, had been having days worth of chest pain. And I show you these vitals and these labs indicate how late presenting this likely was. She was hypotensive, tachycardic. She was already on 15 liters at the time I saw her. We opted to intubate her. We initiated cangrelor in the lab. She had not had any upstream loading downstairs in our emergency department because she needed intubation. There wasn't time for enteral access to be given. Her initial labs, as you can see here, creatinine of 1.9, a high white blood count. Troponins were already 53,000 upon presentation, really indicating this late presentation. And her shock had a lactate of 10 with a pH of 7.15, so very sick. Here's our left system. You can already see the backfilling, the collateralization of the right coronary artery in these shots. I took a big guide, and you can see after just a little injection that there's a really heavy thrombus burden, put in an intra-aortic balloon pump as well to support her. Performed a balloon angioplasty, and then took penumbra down for thrombectomy, and this is what I had subsequently. So extreme high thrombus burden really throughout the RCA system. Briefly show IVUS here just to demonstrate really more proximally in the mid-RCA the heavy degree of disease burden and then clot burden as well present. I'll just show this for a minute and keep going. She was very sick on multiple pressors at this point. So we started cangrelor. She was on IV heparin, trying to get her anticoagulated as much as possible. I inserted a microcatheter. She had significant no reflow, as you can see, and gave intracoronary adenosine and epinephrine and several other vasodilators. And this last frame was essentially the best we ever got. You can see that both her PDA and PL systems have clot distally here. So got a right heart cath because I wanted to know what I needed to do in terms of extra MCS support. So her cardiac index was falsely elevated. She was on now 4 pressors. Her PAPI was 0.3. Her filling pressures, as you can see, were quite high, and her PA sats were 86%. My fellow looked at me and said, we have to recheck those, they're way too high. And at that point, we realized she likely had a shunt from a late presentation. Remember that 53,000 troponin at the beginning, 220,000 on repeat. So we ended up putting in both right and left support to support her bipella. Took her to the unit. She's found to have a VSD. She remained on cangrelor. Our surgeons took her subsequently afterwards to take care of her VSD. So she had a pretty significant VSD, remained on bipella support, ultimately was in the hospital for about 3.5 weeks, and then successfully discharged. But I think in this particular situation, cangrelor was ideal in a patient that was in this much shock, undoubtedly had this much of a lactic acidosis, would not have absorbed an oral P2Y12 inhibitor, was on opiates while being ventilated, didn't have enteral access, had vomited in the emergency department. All of those situations make it ideal agent for patients with cardiogenic shock. So now I'm going to pivot and talk with you all a little bit about the CAMEO registry. It's a US-based registry. We did a sub-analysis of looking at cardiogenic shock patients in this registry. So CAMEO has now enrolled over 5,000 patients across 12 US centers. These are all ACS patients. They had to be adults. They had to be presenting for a STEMI or non-STEMI. And then they had to receive either cangrelor or an oral P2Y12 inhibitor during the first 48 hours of MI hospitalization. We were interested in multiple questions, including how cangrelor is used in cardiogenic shock, bypass surgery, so the perioperative state, how it's used in patients with chronic kidney disease, and how it's transitioned. And so I'm going to talk about a few of those issues here today. So one of the things I think that we saw early on, we've repeated this data. This was always meant to be a quality improvement registry where we took the learnings that we came up with and took them back to our sites to help improve outcomes. So we specifically looked early on, though, at transition patterns for ticagrelor, prasugrel, and clopidogrel. And you all know that there should typically be an overlap, particularly for ticagrelor, a little bit different between FDA and other recommendations, but you can give it as an overlap at the time of discontinuation or prior. Other recommendations would say 30 minutes prior to discontinuation of cangrelor to give the ticagrelor. For clopidogrel, though, you typically give it at the time of discontinuation of the cangrelor, and that can be a very tricky time of transition. And so, in fact, we found that in patients receiving clopidogrel after cangrelor, there was about a 2.5-hour window between when the cangrelor was stopped and when the clopidogrel was loaded. And oftentimes, as you can see, only 60% got an actual loading dose. Keep in mind your half-life for cangrelor is very short, so important to get the P2Y12 inhibitors on quickly. Only 27% of patients were administered cangrelor correctly in our registry in the early days. Now, so let me talk a little bit about cardiogenic shock. And so why do I bring up Champion Phoenix? You all are very familiar with this trial. Looked at the primary efficacy in stent thrombosis comparing cangrelor to clopidogrel, and these were elective or urgent PCI patients. And there was both an improvement or a benefit seen for cangrelor with the efficacy endpoint and stent thrombosis. However, it's really important to note that cardiogenic shock and cardiac arrest patients were excluded in this trial. So there's need for real-world evidence. And before looking at this in Cameo, there was a single small center study looking at about 147 patients that received cangrelor, 26% of them with cardiogenic shock, showing that there was 11 bleeding events in the shock subset. All of them were sort of mild to moderate bleeding. And then in the hemodynamically stable cohort, there were 16 bleeding events. So pretty similar between the two groups. So again, I want to talk about cardiogenic shock and cangrelor. When are the ideal situations for this drug? Patients with heavy thrombus burden, patients that have significant renal dysfunction, because we know the G2B3A inhibitors can really stay around in the system, and particularly if you're using large bore MCS, this can be problematic for bleeding. For patients that need airway, intubation, opiates concomitantly, there's always an issue of oral P2Y12 inhibitors and opiates in their overlap. And then inadequate gut absorption. My patient certainly had a lactate of 10 when they presented, so wouldn't have had great gut absorption. Now, in our sub-analysis, we looked at about 2,400 patients with cangrelor use in our registry. About 250 of them had cardiogenic shock. This was a sick population, so you can see about 36% with diabetes, about a quarter with prior PCI, multivessel disease in about a quarter, and then you can see about 60% got mechanical circulatory support. Many needed thrombectomy, and many needed a duration of MCS that was greater than 5 days. So this was a sick population of patients. What we found is that the duration of cangrelor use in cardiogenic shock on a median was about 4 hours, so a longer duration than what you would typically see if you were using the standard cangrelor bolus and infusion for 2 hours of the duration of the PCI. And you can see that the 75th percentile was 21.5 hours. At my center, certainly, we used cangrelor longer until the patients are in a more hemodynamically stable state where they can take an oral P2Y12 inhibitor, and we know that they'll adequately absorb it. So cangrelor and cardiogenic shock, we show that the median duration was about twice as long for patients with cardiogenic shock as for those patients that were presenting for an AMI without cardiogenic shock. Most transitioned to ticagrelor or prasugrel, about 40 to clopidogrel. And perhaps not surprisingly, increasing age was associated with shorter infusions, the use of MCS with longer infusions. The rates of MACE that we showed here, you may say, well, this is quite high, 42% for MACE, 25% for bleeding among cangrelor-treated cardiogenic shock patients. In U.S. Overall, from our National Cardiovascular Database Registry data of cardiogenic shock patients, this is very similar to what we see for shock patients in terms of MACE and bleeding. So I think very similar to matched patients in other large registries. I mentioned this beforehand, a couple of things that make patients more likely to need longer infusions. Chronic lung disease, I think, is just a marker for intubation, MCS utilization, age extremes associated with shorter infusions. So a couple of important conclusions here. There's really highly variable practices that remain in how we use cangrelor to treat both acute myocardial infarction but also cardiogenic shock. It's important to note that cangrelor can be effective and safe in treating AMI patients without adequate upstream oral P2Y12 inhibition. So many of your patients that are getting upstairs or coming to your cath lab that may have just gotten the oral P2Y12 inhibitor, most of our algorithms, and I think it'll be talked about here in a moment, would feel comfortable with going ahead and giving cangrelor on top of a very recent oral P2Y12 inhibitor to be additive. Cangrelor is frequently used in patients with cardiogenic shock for all of the reasons that I mentioned previously, and then the rates of adverse events in our cangrelor-treated cardiogenic shock population very similar to other large US-based registries. So I'll stop there and take any questions.
Thank you for the great presentation, and that was a great case. So you highlighted the rationale behind why cangrelor is a very good drug in patients with cardiogenic shock. And we know that a lot of these patients do not get well too soon.
Right.
And you spoke a little bit more about the prolonged infusion. So how comfortable do you feel for how long keeping the infusion? Obviously, what we saw in Cameo was one thing, but in your clinical practice?
Yeah, so I think obviously shock doesn't go away immediately after revascularization, or certainly even with adequate MCS support. So in these patients, I think it's critical to have some sort of PA catheter in, to be looking at their hemodynamics in real time. But then I typically, in our practice at Duke, where I practice in North Carolina, we typically let it run longer until we're more comfortable that we can either get enteral access, the patient is hemodynamically more stable. And so what that oftentimes looks like for us is what I would say the PCI dose for 2 to 4 hours, and then sort of a longer infusion strategy. And in many cases, we are using PRU-based strategies to determine what that is for patients to try to minimize bleeding. Our surgeons in particular in perioperative settings like to do that to try to keep the dose as low as possible and avoid increased bleeding risk.
So you may even keep it for days?
Days, potentially.
We have a question. So thank you for a wonderful presentation. You mentioned prolonged infusion beyond 2 to 4 hours in these critical patients. Do you maintain them on the same dose? And we just responded, thank you. So I do have another question. What do you attribute, we've heard from several presentations now, the safety profile. And you have these patients in cardiogenic shock, with Impella, lines, and they don't appear to be bleeding that much, right? What do you attribute that to?
I think in clinical practice, and I'll bring up a couple of points, the nice aspect of cangrelor is the ability to change the dose if you need to reduce bleeding risk after that 2 to 4 hour window. But then it has such a short half-life, onset and offset. So if you do have a bleeding episode, especially associated with access, with large bore access, easy to stop and pause. Whereas with your other agents, and I said this again, the G2B3AA inhibitors, and I think a lot in the US, cangrelor is seen as equivalent, but I want to bring up that in patients with inadequate or low GFRs, G2B3 inhibitor will hang around for a very long time, hours, potentially 12 to 15 hours in a lot of our older patients with low GFRs. Cangrelor is nice because it doesn't have that effect. It's not renally cleared. You can turn it off if you're having a bleeding episode, and it clears from the system, whereas other agents may not.
Roxana, you have a question?
Thank you, Jen. A really great presentation. I'm intrigued even by the first and your presentation with regard to the P2Y12, the oral P2Y12 inhibitor choice. I heard prasugrel, I heard clopidogrel, but the one that's easiest is ticagrelor. And it seems even in the Cameo registry that most of it was either, and high levels of clopidogrel loading, even in these like non-STEMI, STEMI patients. Do you want to comment on that? And what's wrong with ticagrelor?
No, I think ticagrelor is obviously, I think, the agent most of us would go to. There are, if you could look at the population demographics, there are population with concomitant AFib, and so they're knowing that up front and knowing they've got to go to clopidogrel and potentially apixaban. But then I think there's also just a fear in these older patients that using these high-intensity P2Y12 inhibitors result in more bleeding. But in fact, we know that oftentimes those are the patients that have the highest ischemic risk, and we should be using the higher intensity P2Y12 inhibitors. Obviously, ticagrelor ideal because it doesn't have the issues with stroke that prasugrel does. So I think it's also just a message that there's maybe an overabundant use of clopidogrel in a lot of our sickest patients because of a fear of bleeding downstream.
Perfect. Well, thank you so much, Jen.
Thank you.
So it's a pleasure to introduce our next speaker, friend and colleague, Dr. Roxana Moran, who will be showing another interesting case, followed by a review of the SMILE registry. Roxana, thank you so much.
Thank you, Dr. Angelillo. Very similar. I've got a case from our experience of a woman, a 65-year-old woman, normal weight, hypertension, dyslipidemia, and type 2 diabetes, prior GI bleeding due to a gastric ulcer, and with chronic anemia, her baseline hemoglobin being 10, and CKD at 45 cc's per minute for eGFR. She was taking a PPI, ramipril, atorvastatin at 10, and metformin. She presented to the emergency room with crushing chest pain, started about 2 hours while she was watching TV. This was her baseline ECG, persistence chest pain, hemodynamically stable, and a very quick echo. We do this a lot in the ER with LVEF of 35%. She was given aspirin and transferred up to the cath lab. You see the right coronary is non-dominant, but here's her left system, and you see the totally occluded left anterior descending artery, and in which lines up with her ECG. So she was given unfractionated heparin, and immediately on the table as she's lying there, she was sort of hemodynamically stable. She was given ticagrelor loading dose. We did give ticagrelor. And then we proceeded with wiring the vessel, going down and using our pre-dilatation techniques and actually going into both LAD and the diagonal, putting in a drug-eluting stent, a 40 millimeter and a 15 millimeter DES in this, and here's what we got. Complete no reflow. We're giving intracoronary nitrates, intracoronary adenosine, and this is the exact thing that we saw in Champion Phoenix with the intraprocedural thrombosis and no reflow. This patient begins to have some nausea and vomiting, becomes restless, progressively unstable, and now she's unresponsive, requiring resuscitation and intubation. And we proceed quickly with an Impella device and start cangrelor immediately. And it worked. The vessel opened, and we don't know if it was the unloading or the cangrelor, but the truth is both together. At this point, we transferred the patient to the ICU. She was hemodynamically stable with the Impella device, and then it was removed and she was sent home. And you could see here that there was this, exactly how we did this is unfractionated heparin, aspirin, cangrelor in the cath lab, but a continued infusion up to about 24 hours. We went to a reduced dose of cangrelor during that second infusion as we continued on, about up to 24 hours. Switched over to oral aspirin. She was extubated and weaned and then received oral aspirin and then ticagrelor. She had, I remember, received the ticagrelor at the time of the PCI already at 180 milligrams. So I think the key points of this particular case is that obviously we heard about the gastrointestinal issues, how she began to vomit, but really important that giving her that ticagrelor up front doesn't preclude you to use cangrelor. And I think that's a really important point to take home. Many would have, if you don't understand the mechanisms, you might think that, but the truth is that you could still give cangrelor. It's effective in PCI, especially in these types of patients, and can be easily transitioned with no pharmacologic interaction. And I think this strategy, with or without the reloading, depends on prior ticagrelor. Both of them are safe, especially in a case like this that you just saw. This patient had received the loading dose, so we just went without loading and went to the 90. So that's our case, and then I want to talk to you a little bit about the SMILE registry. Obviously, really important, the fact that the platelet inhibition landscape is massive these days. That timing, that early timing, in that early time period with both ischemic and bleeding complications really sets the stage, especially for the patients who've never been loaded, who present with an acute coronary syndrome, high clot burden, complex disease, or even those who you have some issue with intraprocedural no reflow or thrombosis. The only intravenous administered P2Y12 inhibitor is cangrelor, an ATP analog that's direct acting with a quick onset and offset, time to maximal effect of just 2 minutes with 98% platelet inhibition, and with the reversible binding to the P2Y12 receptor. And I think this is very, very important. And the fact that within an hour after discontinuation, and that's an important piece of information, that the platelet function comes back to its baseline. And this interaction of the drug-drug interaction is something that has been very well studied. Back in 2008 in thrombosis research, Steve Steinhubel took 20 healthy volunteers, had 2 groups, actually it's really 3 groups. The group 1 receives a cangrelor IV bolus, and at the end of the cangrelor infusion receives the clopidogrel. That's group 1. So it's the clopidogrel after termination of the cangrelor infusion. Then this other group within this 10 patients in group 2A, clopidogrel is given orally for 6 hours, and then you wait for a 2-week washout, and then so those patients have their blood work done, and then you're remeasuring platelet function, and then you basically are looking at the group 2B with a 600 milligram oral dose plus cangrelor at the time of the infusion. So what was found here, which I think is really important, is that the simultaneous administration of cangrelor with the loading dose of the clopidogrel, of cangrelor, actually prevents a need for that loading dose of 600 milligram loading dose of clopidogrel from inhibiting the platelet function at 4 to 6 hours. And you see the curves here, and I think this is a very, very important observation. In SWAP 6, where there was this also important drug interaction with prasugrel, they found that the concomitant administration of prasugrel and cangrelor actually had some increased platelet reactivity after stopping the cangrelor infusion, and I think that's also very, very important to take into account. Whereas with ticagrelor, there is no drug interaction, and it's a really smooth transition because of the mechanism of action and how it works really, really nicely. You could pre-treat with ticagrelor. You could use the concomitant treatment with ticagrelor and cangrelor with no issue because of the way this is working, and you see how the receptors are working here. And of course, ticagrelor and metabolite only available group, as you see here. And it's a very, very important understanding that for us to note that co-administration of ticagrelor and cangrelor is quite nicely done, whereas with there is might be some issues with just clopidogrel alone. So there are all of these, and I think it's important to understand how to do this oral transition to the oral P2Y12 inhibitor. And what we've done in our institution, and it would be interesting to know how many of you have actually institutional standard operating procedures in terms of doing this to follow the directions as it says in the IFU instructions for use for cangrelor. And I often see, and we saw that in the Cameo registry, how little people are following these important issues. And what happens in the clinical practice is very, very important. And as a result, we at Mount Sinai, we do have a protocol, but what we looked at is all of our cases from 2018 and 2024 to understand the real-world contemporary use of cangrelor and the transition modalities to oral P2Y12 in patients undergoing PCI, looked at MACE, and of course, we had 543 patients and 493 with available data, and we actually went back to look and examine, and these are not things we had usually collect in our database. When was the drug stopped? When did we transition into? This was a lot of work by our entire team, and Angela Oliva was the lead author of this paper that was presented last year at TCT. And 80% of our patients transition over to ticagrelor, with about 20% with clopidogrel and prasugrel for multiple reasons. Operators and of course the idea of use of prasugrel with a once-a-day drug and what they would like to do, and then worried about bleeding, as we heard with clopidogrel. These were mostly high-risk PCI or ACS patients, complex features, either thrombotic lesions or intubated patients or poor intestinal. And this is our current idea of how to deal with this. And what you are doing is the cangrelor, you're deciding to give cangrelor, you start with a bolus and a standard dose infusion, and then you can, if you decide, for an overnight infusion to give a low dose of 0.75 mics per kilo per minute, or you can wait until, or whenever it is, or when a patient can go to the oral P2Y12 and you can transition to ticagrelor, clopidogrel, or prasugrel. With each of these, ticagrelor can be given anytime. This is our protocol, 180 milligrams anytime during cangrelor infusion or immediately after discontinuation. With clopidogrel, immediately after discontinuation, especially because we're worried about that very important one within an hour and the possibility of malabsorption or non-absorption with clopidogrel. And then the prasugrel, 60 milligrams immediately after discontinuation. And this is literally what we are supposed to follow. So we looked at all of this. Most of the patients were a complex PCI, about 79%, MCS, about 22.9%, cardiogenic shock, 15% of these patients, a good number of 36% with high bleeding risk, multivessel disease, 55%, and a femoral axis in almost half of these patients. The median duration of cangrelor was about 183 minutes. 28% received low dose, received a standard and a low dose, and that low dose could have gone up to about 20 hours. 80%, as I said, to clopidogrel, and 20% with the rest. But what's really important is the protocol adherence in terms of transition. And the protocol adherent with ticagrelor was quite good, easy to do, 90%. Non-adherent, about 11%, whereas whenever it was with clopidogrel or prasugrel, we saw a lot of protocol non-adherence for one reason or another. And obviously, this is an important piece. Here's the metrics and the transition, and you see that in those patients who received upstream P2Y12 transition ticagrelor and transition up to ticagrelor was about 243 of these patients, most of these P2Y12 naive. Those not receiving on upstream P2Y12 inhibition, but transition to ticagrelor. All of these received, obviously, cangrelor infusion. That's in green arrows there. And you see the two other, those who had received the upstream P2Y12 transition to clopidogrel or prasugrel, and then those not receiving the upstream and transitioning. And you see the difference here is this the vulnerable phase that we've put here, absence of adequate platelet inhibition after cangrelor discontinuation when you're going to these different dosing. And I think this is a really important piece of this. And what we found very importantly is that if you use ticagrelor and adhere to the protocol, there was a much better in-hospital clinical outcomes in terms of MACE. Now, listen, there's a lot of unmeasured confounders here. This was not a randomized study, lots and lots of limitations, but it really tells you how important it is to follow protocols and not to have shortcuts and not to have a heterogeneous treatment or just following what needs to happen in order to make sure that everything is done well and that all of the staff are well informed about what to do. And we use mostly ticagrelor. And I think the key points here that with cangrelor, you get this very prompt, potent, reliable antiplatelet effects, and it allows you to overcome the limitations. And of course, because of the fact that they have this inevitable delay of their onset of action. And of course, cangrelor is the ideal agent, the only one, I think, that reduces these intravenous one, reducing thrombotic complications, especially in the procedure. We've seen this a lot, and especially if you've never seen a P2Y12 inhibitor before, and also when there is a problem with absorption. In this real-world registry of SMILE, the ticagrelor and adherence to the protocol transitioning to an oral P2Y12 is associated with a much, much better hospital outcome. And these results, I think, obviously small sample size, lots of things I tell you, but it tells you that it would be important to better educate our teams and to really use the best application of the cangrelor. And in order to do this, we really do need to have much, much more real-world data. And these registries are really, really important, but I think we need much more. And hopefully we could get to the best possible place. I do believe that we're underutilizing cangrelor, to be honest, even in a very high volume hospital like ours. It was slow for us to start to use it, but we're now seeing an uptick, especially in those patients who have complex PCI, never have seen a P2Y12 inhibitor and present with an acute coronary syndrome. Thank you so much for your attention.
So thank you very much, Dr. Moran, for sharing this very much needed clinical data. And because we are running of time, we will answer any emerging questions at the end of the session. So Dr. Kao will present the state-of-the-art use of intravenous antiplatelet agents.
We will discuss briefly what are the future insights in IV therapies. So first of all, let's answer the question, why do we need IV agents? Well, the guideline says in every patient who is naive from P2Y12 inhibitor, but there are obviously clinical scenarios when this is more desirable. And we've reviewed all these cases in the 3 wonderful presentations when there's delayed gut absorption in patients with cardiogenic shock who are heavily sedated or who are vomiting. In the very first case, we had a high-risk non-STEMI elevation, non-ST elevation patients with a pre-shock state that developed cardiac arrest. Second case was a STEMI with cardiogenic shock, intubated, sedated with a high thrombus burden, which required a bipella mechanical support. And then a STEMI complicated by Noriflow. Now, if we see these cases, it comes immediately to your mind, why do we need IV agents? The reason is the rapid onset of action, because we are able to inhibit all the platelets, provide full P2Y12 blockade within 2 minutes of administration, as opposed to 2 to 4 hours of oral agents, but also rapid offset of action, 6 minutes after interruption of infusion, as opposed to 1 week, which is the ideal, which makes it the ideal drug if we have, for instance, a bleeding complication, so we have to undergo emergency surgery. Now, unfortunately, the evidence supporting cangrelor comes from studies that have been designed on different patient population. The 3 CHAMPION trials were conducted on a largely stable coronary artery disease population, not the shock cases that we just reviewed, and used only clopidogrel for transition as an active comparator. Nonetheless, even in this low-risk population, we were able to see a significant benefit in terms of MACE risk reduction, and especially a reduction of the incidence of stent thrombosis by approximately 40% in the first 48 hours. So why are we now speaking of real-world evidence? Why do we need to review these cases? Well, the answer is because we're actually using cangrelor in a slightly different way of how it was tested. We're using cangrelor in much higher risk ACS patients. We think it's the ideal drug for patients with complex coronary anatomy, patients obviously with cardiogenic shock or cardiac arrest, patients that are high bleeding risk for the offset pharmacodynamics that we just discussed. But there's some confusion, and also this is a good opportunity to clarify what are the clear infusion and transition protocols that we need to follow to minimize the risk of drug-drug interaction with oral agents. Now, I want to highlight why are we presenting this registry once again. If you see, Champion Phoenix had a very minor proportion of STEMI and non-STEMI cases as opposed to the 3 registries that we just reviewed. Almost no cardiogenic shock in nearly 20,000 patients in Champion as opposed to 30 or 40% patients presenting with cardiogenic shock in the 3 registries. And of course, practice has evolved since 2010, 2012, which much lower use of femoral access in favor of radial access and almost no use of bare metal stents anymore. Once again, look at the transitions between what we've observed in randomized controlled trials. In Champion, 100% of patients transitioned from cangrelor to clopidogrel by protocol design, and about 80% in the real-world registries that we've just reviewed. Now, we have IFAU and indications for use, drug labeling from the FDA. It should be used for at least 2 hours or until the end of the intervention, whichever is longer. And here in Europe, the infusion should not exceed 4 hours. But we've seen that there are cases where the patient may benefit from a prolonged infusion. Also important is the transition to oral antiplatelet agent, and we've seen that if we use clopidogrel or prasugrel, because of the exact timing that we need to administer the drug to avoid drug-drug interaction, there's a much higher risk of transition protocol non-adherence as opposed to ticagrelor that we can essentially administer at any time during the infusion. If we look at the outcomes and compare the outcomes, we should not do that because the patient population are drastically different. We have a 4% rates of MACE in Champion as opposed to a 13%, but these essentially reflect the clinical conditions and the shock conditions of many of the patients that are treated with cangrelor as opposed to these regulatory trials. And the same can be said for the bleeding rates. So what have we learned from these presentations today is that indications for and modalities of cangrelor use in routine practice differ from those of an RCT setting. Real-world data suggests cangrelor is preferred and probably should be preferred to oral antiplatelet agent in more high-risk cases. Adherence to infusion protocols and transition rules may have important clinical implications, especially for the risk of drug-drug interactions, and therefore opportunity exists to extend and improve cangrelor use in sicker and more complex patients. One such opportunity was provided by the Arcangelo study, an Italian prospective registry involving only ACS patients. We can see that most of the patients were transitioned to ticagrelor, 73%, 5% bleeding rate, much higher of that of Champion Phoenix, but only 0.3% for which it could be established a causal relationship with cangrelor. What is next? This is an important trial that we shed light in the cardiogenic shock application of cangrelor, tested in a randomized fashion against crushed ticagrelor. And finally, we still have knowledge gaps and things we need to understand with respect to transition into prasugrel, high bleeding risk patients, complex PCI, and so on. Thank you.
Thank you, Davide. I want to make sure that we address all the questions that came from the audience. There's one question: do we have some data on maximum continued infusion of cangrelor? The best data we have is actually from the Bridge trial in a randomized fashion where the infusion was up to 7 days. We have a second question.
safe. I think it's important.
And it was safe.
Yeah.
And it was safe. Second question, use of intracoronary thrombolysis for a no reflow.
So whereas there are indeed some published cases, the data does not support such a therapy. There are some centers who are using that, but we don't have absolutely no data that it's successful. But following on that, I can tell you, in my opinion, in my experience with use of cangrelor, the best prevention of no reflow in patients with plaque rupture in STEMI is to use cangrelor, like to prevent this no reflow. So like my strategy is always, if I see if there's plaque rupture, huge thrombus burden, to wire the vessel, use a pre-dilatation with low atmospheres just to have some flow, then to use the cangrelor bolus, and then go with stenting and so on. With this strategy, it's really, I saw in my clinical practice that this is very, very successful in prevention of such a no reflow.
Okay, well, thank you so much. We have 30 seconds left. I want to start off with thanking all the speakers for the great presentations and showing real-world cases. We've learned that there's a little bit of a disconnect between the way the trial was conducted and the way the drug is actually being used. But this is extremely informative. I would like to thank Chiesi for setting up this wonderful and interactive symposium where we discuss truly challenging cases, and hopefully there'll be take-home messages for all of you. Enjoy the rest of your meeting. Thank you so much.